we'll have questions, and I will go ahead and proceed and ask a couple myself. Ms. Allen, y'all, you can tell I'm from Texas with the y'all, but you have educated me as well as other specialists in oncology on the present setting in which cancer patients receive their treatment. And what I refer to as the old days or previous days was a hospital setting. That's no longer true. And there is one area of concern the past couple of years, what's more than 2 years, and I just want to know what is the status, and that basically was where the oncologist or the cancer treatment facility was actually being reimbursed for the drugs that were being utilized at something less than the actual cost to you. Can you elaborate on that?
That continues to be an ongoing problem. The Medicare Advantage plan has certainly not helped that. The 20%, if we don't collect 100% of the allowed charge, the 80 plus the 20, we are not covering the cost of the drug, which certainly doesn't begin to address the pharmacist, the registered nurse, and everything along it. So that 20% for us to chase has become more vital just to our survival at this point. With Medicare Advantage coming on board and with the reimbursement for drugs continuing to decrease, I have had to add 3 additional staff members to access foundation programs for coinsurance, which helps with some drug-specific conditions, but certainly doesn't cover the entire 20%. We are, I think that's a total of about $115,000 that we've expended, and that's just to try and maintain the revenue. We're not gaining anything there, but an additional cost. We are putting in additional systems to try and streamline our practices and to be more cost effective, but at some point you have to hire more people to chase dollars that are harder to find. So it's still a huge issue for our practice.
So it continues, because I know we've been trying to get their attention, and I know we have some meetings set up for CMS not to basically recognize what has been the past practices that actually were encouraged by them by regulation, and then switching over to regulation. And I think that's one of the reasons that we're here today. So again, just thank you for your testimony. I'd like to go to Mr. Schrad, and this is interesting, I guess. What happens? I mean, first of all, you're telling me because of the regulation, because of the unnecessary and maybe burdensome regulatory scheme that we have fewer and fewer doctors, healthcare providers that are available to you to utilize. I think that's the gist of your testimony. That's the greatest impact. We have many other side issues, but first, how about just availability and accessibility, which is going to be major, and we're always reminded of that by the different physicians. I also want to ask, what is the practical aspect of if something is challenged, and we keep talking about it, denial and so on, what happens to the payments that are pending or prospectively while something is being examined and for potential denial, which already has been a preliminary finding that they're going to deny it or that there's a problem? We've had examples that have been cited by different witnesses. But what's the practical implication, let's say, to you as far as billing and such?
The impact is quite large. We have to, basically, we're on our company, we're on a cash basis. So if we don't have the revenue coming in, the actual payment coming in, we just sit on it, and then that's less revenue coming in per month. But we look at all revenue by the month. And there's sometimes we don't get payment for 10, 11 months, depending on what the denial was. So if we don't have it, then we don't have it to spend either. So that's just one of the challenges that the staff are working on every day, and it's an everyday occurrence. This is nothing new. It's been going on for years and years and years. But at the Oklahoma Allergy and Asthma Clinic, we have 2 devoted individuals who work very well and very close with CMS to streamline this, and some things are rectified very quickly, and some things take several months.
All right. So, I appreciate it. And I apologize for the hoopla over there. Those are not members of Congress, I assure you. We're never that happy. I mean,
they were cheering on their answers.
Oh, but it could be the answers. Let me go on to Ms. Wolf. There was something that just very interesting, and you lay it out, but the end effect of this 14-day rule, of when a test is ordered, it relates back to the time that it's actually ordered, which may be in the hospital setting. Then who is the responsible person? Even though it may be, even at that point, it's referred to someone else who makes that determination. It still kind of goes back in time, and there's a lot of liability issues there, people that are assuming. But this is the paragraph, and I know that you touched about, just have to really get this in the record. In light of these and other administrative and financial disincentives, hospitals are encouraging physicians to delay ordering the test until after the 14 days.
That is correct.
And if you can get a little closer to the mic.
I'm sorry. That is correct, because otherwise the hospital will have to assume financial responsibility either by billing Part A if the specimen was collected during an outpatient encounter, and that's very difficult because many of these tests are billed using what they call miscellaneous codes, which don't have coverage and coverage amounts with MACs other than their home MAC, which would create a policy. Or if the specimen was collected during an inpatient encounter, it has to be absorbed by the hospital in their DRG payment, which certainly are not developed to take into consideration these expensive new technologies.
But it's amazing that it impacts a decision of a physician in a certain setting because of the relating back aspect of it. I mean, I can't imagine. I am not saying that a physician would delay anything that would be of greatest importance where time is of the essence, but there's sometimes we're not real sure. You know, we catch things, we don't believe that they're a problem at that point in time, but sometimes a delay, no doubt. I know I would not want my test delayed because of the 14-day relating back. That's the way I'm going to refer to it, the relate back. You do say that CMS is listening, there is dialogue, there is discussion.
There is dialogue, but this dialogue has been going on for quite a while, and we cannot seem to get resolution on this issue. And as you so rightly point out, it is typically not the hospital itself that is making the decision that this test needs to be ordered. It is a clinician as a follow-up to the hospital encounter, and the results of this test and the others that are impacted by this rule are used strictly for patient management decisions that are made that are unrelated to the encounter where that specimen was collected.
Well, thank you very much for your testimony, and I'd like to follow up on that discussion of the 14-day rule, and I understand there may be some logic to it, but it just does, again, the practical application. The theory is good, and then the practice is never. But, Ms. Deacon, let me ask you a question. Obviously, with additional operating costs, gasoline's one of them, and we have many members that are here today and especially on the floor that are championing the rural aspects of health care. You have your operation, whatever, 700,000 miles to see home health and hospice patients.
Yes, sir.
There's no way you can build in that additional cost. Does Medicare, does CMS, does anybody go and say, gee, because of the nature of your practice, of the health care that you provide, which entails going to, and obviously transportation.
Exactly.
That is not factored in.
No, sir, it isn't. Under our current reimbursement system, we are reimbursed on an episodic payment, which means that there is a configuration of information that goes into Medicare. The conglomerate is a number that comes up, and that's how we are paid based on the diagnosis code and some other numbers that go in. And that, for that patient, is all we get. It's a one-number deal for us. None of our costs like that, none of our costs are separately considered in terms of reimbursement. In the old days when we had cost reimbursement, yes, those figures were looked at, but not today. So those are absorbed into any amounts that we get back for reimbursement.
But it is such a relevant factor depending on the setting of the healthcare provider, and and it has to be addressed one way or another. Well, thank you very much. At this time, the chair is going to recognize Ms. Fallon for her questions.